Hello, welcome to this special podcast. We're here to talk about Lepra's new global strategy for 2024 to 2030. I'm Jimmy Innes, I'm the CEO of Lepra in the UK, and I'm here with some of my colleagues who are, in no particular order. On my left here is Radhika Mamidi, who is the state coordinator for Andhra Pradesh, Telangana and Maharashtra in India, working with our partner, the Lepra Society of India. I'm also joined by Arun Kumar, who is the head of programs and resource mobilization at Lepra Society of India based in Hyderabad, and Suzanne McCarthy, who is the chair of Lepra in the UK. And it's brilliant to have you all here. Thank you for joining me on the sofa.
Thank you.
Thank
for
you,
inviting
Jimmy.
us.
Thank you for inviting us.
Brilliant. So we're going to talk about some of the aspects of our new global strategy. It took us a long while to develop it, more than a year. It was a participatory exercise. Lots of people contributed to it. We consulted far and wide, and we're all really proud of the result that we came up with. And we're going to pick up on a few of the key aspects, the key points of that strategy to tell you about today. But before we do that, I'm going to come to you, Suzanne, and ask you, can you tell us a bit more about Lepra, about what Lepra is, the organization, and what it's all about, please?
Well, Lepra has been going for just over 100 years, and Lepra is about care and treatment, support and advocacy for those with leprosy and LF. Over that 100 years, Lepra has had some wonderful achievements, like creating the first real drug treatment for leprosy in Dapsone. And as we come up now to face our next centenary period, we are thinking about the future, and that's what the global strategy is all about.
Excellent. And you've talked there about Dapsone. And for our viewers and listeners for the podcast, Dapsone was developed in the 1940s. It was the first known cure for leprosy. And Lepra at that time played a big role in the initial clinical trials of Dapsone. We're very proud of our role in supporting the development of that drug till it was able to be distributed to people affected by leprosy. And since 1982, I think it is, the WHO has given Dapsone, as well as other drugs, free to anybody in the world who is diagnosed positive with leprosy. And so until today, Dapsone is still used.
I should say, Jimmy, and I'm probably going to have other people in the podcast talk about this, but research has become one of the big issues in our new global strategy.
Thinking about our 101-year history as an organization, we started off in 1924 as BELRA, wasn't it? The British Empire Leprosy Relief Association. And from those early days, we always had a connection with India. But today, our relationship with India is as two peers. We are two separate autonomous organizations. Arun, can you tell us a bit more about how that works, about the Indian entity that is Lepra Society?
Yeah, actually, I can say that we have taken the roots very carefully with respect to the initiation is concerned, right from the 1924, where the disease were very high endemic at the time. But formally, I think most of our founders has really taken the legacy of taking forward all the plans. And in 1989, the Lepra in itself has registered as an individual entity based at Hyderabad. It's a southern part of India. And since then, I think it has been almost nearly 34 years. We are working closely with the Lepra UK and the team as long as, as it just started in 1924.
Exactly, and we call this the One Lepra Family.
One Lepra Family.
And that's a really important part that we're going to talk about in the strategy, isn't it?
Yes.
What that means, what does One Lepra mean? And so when we look at Lepra, I'm the CEO in the UK, but there's a CEO in India. You are the head of programs in India, but there's a head of programs in UK. You are the chair, there's a chair in India. So we are peer-to-peer, and it's an important point. But it's not just India. Where else do we work? Can you tell us a bit more about that, Suzanne?
Well, we obviously work also in Bangladesh, and interestingly, that is actually a country program that comes directly under Lepra UK. So I am the chair of that board, and my trustees are actually those that are watching over the delivery of what we expect to achieve in Bangladesh itself.
Yeah. And we've been in Bangladesh, I don't know, way before my time, way before any of our time, but 30 plus years Lepra has been operating in Bangladesh as well. And so when we look at that, our global footprint, if you like, Here in the UK, where we're recording this, we're about 25 people working to support the programs in India and Bangladesh. In Bangladesh, we're about 30 people working in about 7 districts of the country there. And in India, how many people are we?
Yeah, we are having about 400 plus people.
400 plus. 25 in the UK, 30 in Bangladesh, 400 plus, 500 in India. And it just goes to show the importance of the work addressing and supporting leprosy and lymphatic filariasis in India, which, as we know, has the highest burden of any country in the world.
And we could do more in India because, as I understand, we're only in 9 states.
Absolutely.
And
Actually, as
so-
you rightly said, we are having about global burden. Almost 54% of the global burden is in India
Yeah,
for the leprosy, and also about 40% of the global burden of lymphatic filariasis in India.
yeah,
It's a sheer number of the not only the number of the patients we're trying to serve. Yeah.
yeah.
We also selected the operational areas like where there is high endemicity of the leprosy and lymphatic filariasis, and also high incidence, that where there are new cases were being coming up in the states. We are focusing almost in 10 states in India.
In 10 states. And you oversee how many?
I look after 3 states: Andhra Pradesh, Telangana and Maharashtra.
Good. And are those, do they, in terms of the number of cases, are they near the top, in the middle?
Yes, presently Andhra Pradesh is also getting more number of cases due to the campaigns that were taken up by the government, and also Telangana and Maharashtra are high endemic for leprosy.
Yeah.
And Maharashtra, it's one of the top 3 states where there is endemicity is there in India, which
Yeah.
contributes to the highest burden in the country.
Can I add actually? Maharashtra is it is rated as a top number 1 state for the high endemicity. If at all we try to take the statistics of 23-24, it's having about nearly 20,000 cases.
In one
And
state.
we are having also one of the high endemic district in Maharashtra where we are also working.
So
Yeah.
Chandrapur is the district where we are covering 8 blocks. We found more number of cases in one campaign. We could able to identify more than 1,000 plus cases within a span of 20 days of time. So we will choose strategically the operational sites where the need is there to serve the community.
Yeah. And for me, I travel to India once, twice a year to visit the work and to work with the team. And I still can't comprehend the size and scope of India as a country. 1.5 billion people. And then you have a state like Bihar, which is about the same size as the UK, but with, what's the population of Bihar now?
It's about 12 crores,
Which is
about
120 million.
million, yes.
120 million people in an area which is about the size of the UK, and that's one state of India
Absolutely.
out of 30 plus, 36 plus states. So yes, all very good. Thank you very much. And I'd like us to come now on to the strategy a bit more. When I talk about the strategy in different conversations, meetings, presentations, etc., I always pick up on 5 key points which I want to communicate to people. And we're going to cover some of those now, and we'll ask you each to talk a bit about those points. But the first one, to me, is I'll just talk about that, which is it's about leprosy and lymphatic filariasis. Now, Lepra has always worked to support people affected by leprosy. It's the clues in the name, yeah? It is what we are, who we are, what we do, always have done. And we're very proud of that long, rich history. But in recent years, decades, we've also started working more in another disease called lymphatic filariasis, which most viewers and listeners will not know that name, but will be familiar with the term elephantiasis, which has connotations with swellings in the leg, and people may be familiar with that. We don't use that term. We find it stigmatizing. We tend to refer to it as lymphatic filariasis, or in short, LF. So we'll be referring to it as LF in this conversation. And LF is different to leprosy. Leprosy is a bacteria. LF is transmitted from mosquitoes, and it's about minuscule microscopic larvae in the body which multiply and gravitate towards the legs and cause swellings. They're treated differently, but there are similarities because the way you manage the signs and symptoms of leprosy aren't dissimilar to the way you manage LF. Can you tell us quickly a bit more about that, Radhika?
Yes, this is in terms of similarities, like the work with the experiences from the leprosy. We took combined approach strategy where we are integrating the diseases of leprosy and lymphatic filariasis, and communities were also well accepting to come together and get the services, because in leprosy we call it as a disability prevention and medical rehabilitation, and in NVBDCP under LF we call it as a morbidity management and disability prevention. So in terms of services, what we provide, we do provide physio care and services for both leprosy and lymphatic filariasis. We provide health education, we provide counseling services, we give aids and appliances for both the disease affected persons. So considering this, Lepra with its experiences, we thought that we can take up this combined approach strategy in all our operational areas where there is a mixed endemicity of leprosy and LF. This is helping us a lot, and it's a cost effective also. Good. So that we can reach more number of populations with the same staff, and we can bring changes in the lives of persons affected, especially with leprosy and LF.
Great. And up until now, we have been a leprosy organization that also works in LF. But our new strategy is now saying to the world, no, we are a leprosy and LF organization. They are on an equal footing in our minds. We work on both. And as Radhika is saying there, we do so, we're trying to integrate that as much as possible in our work. Excellent. So when I'm talking to people, that's the first thing I like to mention. And then the other four, to name them quickly, is about our 3 key goals of health, inclusion, innovation. And it's about our One Lepra partnership, about how we work as one unified approach and family. So I'd like us to talk a bit more about those. So Arun, coming to you, health is one of the key outcomes in our new strategy. What is that all about?
Okay. Thank you, Jimmy, for raising this. As you're saying, actually, we try to see that health is a wealth. What we try to see is. And that is also most importantly, more important for the leprosy and LF patients. Because for some of the patients, it is about lifelong consequences, we just try to have it. So as a part of our strategy, what we try to have is primary care, secondary care, and tertiary care, we just try to provide it. But I'll just try to sum up with respect to the 3 outcomes we could really plan for the strategy, under the strategy. One is actually as a part of the health, what we try to do is, we try to build on the strengthening of the health systems. That's the outcome number 1, we just try to have it. As a part of it, basically we just try to build the capacities of the general health staff. Why I'm saying this
of the government health
of the government health staff. So basically what we try to do is, whatever we try to work, it's a kind of integrated approach, we try to look into it. If at all we just try to see as a part of the leprosy care services in the government health centers. So leprosy is now integrated into the general health systems. And most of the people are not really aware of how to diagnose a disease, and as well as with respect to the treat the disease. So our basically mandate is to provide them with respect to the technical guidance on training them. What we try to do is, as a part of the training, basically what we just try to do is, so we try to put leprosy as an agenda to their regular work. Basically we just try to do that. And
so we're trying to raise the profile of leprosy within the general health service.
General health service, yes.
And we do that, sorry to interrupt, but we do that, we have referral centres, don't we?
Yes.
How does a referral centre work? How does that make it happen?
Yeah, referral centers, we provide the direct service delivery. In addition to this, the trained staff who were engaged in the referral centers will provide training programs to the ASHA workers who are working. ASHA is an accredited social health activist.
Like a community health worker.
Yes, she is a health worker of the government, where she could able to suspect the cases in the communities and refer to the health facilities.
Great. So the referral centre is a health centre which is attached to a government health centre or clinic, where we provide specialised leprosy and LF care and services, and then refer patients into the government health system. Is that right?
Yes.
Good.
As a part of actually, as I said, we are having in almost 146 locations this referral center. where we try to provide the primary health care, primary services, secondary services, and tertiary services. In all the 146 locations, we'll try to work closely with the government health staff,
Good.
training them and meeting the demands of the patients at the government health centers.
Super. And Radhika, can you tell us a bit more about early case detection
Yes.
and why that's important?
Yeah, it's very important to identify the case at the early stage. It's two
Of
types
leprosy,
of
yeah?
of leprosy. It's a paucibacillary and the multibacillary, because the treatment regimen for the PB is 6 months and MB is at 12 months. And if we won't diagnose it early, there might be a chance of getting disabilities among the persons affected with leprosy. And even with the LF also, if we won't identify early, we could not able to manage the morbidities. There are different grades in the lymphatic filariasis. If it is to the elephantiasis stage, it would be very difficult to reduce the swollen legs or the affected parts. So we promote early case detection in the form of survey programs, the outreach workers which were positioned by Lepra Society, and also by training the government health staff, we
Good.
conduct the survey programs.
And one thing which, the way I think about it, is the problem with leprosy and lymphatic filariasis is we tend to have to wait for people to come to a health centre. I'm worried about my symptoms, I need to get tested. But there are barriers to that. Maybe there's money barriers or geographical barriers or cultural barriers or stigma barriers because people are worried and don't want their diagnosis to become known.
Yeah.
So if we can't wait for people to come to us, we have to go to the people. And we call that active case finding, where basically we're going community to community, village to village, door to door, looking for the signs and symptoms of LF and leprosy infection so that we can diagnose early and treat as early as possible, isn't it?
Yes, the government is also coming up with campaigns where they generate awareness in the communities, where lepra is also being part and engaged in the campaigns for planning and designing the leprosy case detection campaigns and SPURS leprosy awareness programs, where we train the government healthcare functionaries and we also monitor the LCDC programs so that we can support the government to get identified cases at the early stage. So here Lepra Society and the other ILEP organizations also plays a key role in taking up the technical, in terms of technical aspects, where trainings were being conducted with the support of the government to all the health functionaries. And also we plan for the surveys, and also we also take some of the cases in the form of passive case detection. So we engage the dermatologists, private healthcare providers, and other key dermatologists, so that they can also refer cases to our referral centers and the government health facilities.
Jimmy, I just wonder if we could say something about how we specifically work to be able to engage with women and children in a way that's positive, because often they won't come forward.
And you're right, because the statistics tell us that there are more cases of leprosy amongst men than there are of women, but that's
knows?
not true, is it?
Yes.
It's just because we're only detecting more cases in men, we haven't got the opportunity to detect as many cases in women. How is that on the ground and in reality?
Yes, when we look into the figures, it's a 50-50% of men and women. But
In reality.
In reality,
Yeah.
but it might be the more because the cultural barriers, family barriers, self-stigma among the women for accessing the services is definitely there in India. So Lepra Society is promoting equity for women and children, where we keep prioritize our work, looking that these women and children get better access to the services. So we work closely with the women self-help groups, and also we work with the schools and college institutions, so that the people get aware and educated and they can access to the services. So we strategically plan to engage, and we keep gender sensitivity definitely while we designing our programs.
Brilliant. And I think that's a great segue into the next point we wanted to cover, which is about inclusion. So our three key goals in our strategy are health, inclusion, innovation. And maybe now we'll come to you, Radhika. Tell us, what is in our strategy, what do we mean when we say inclusion?
Yeah, from planning itself, Lepra Society, we recognize that inclusion is a part, and because we recognize that persons affected with leprosy has multiple layers of marginalization in terms of gender aspects, in terms of disabilities, in terms of age. So we started designing our programs with a community participatory approach, and also the inclusion. What we think, as I mentioned, is gender sensitivity aspects. We take up the gender sensitivity aspects, and we also see many people affected by leprosy are disabled, so we add the disability as an inclusion part. And as a patient continuum of care, I would like to tell that it's not only the medical needs what Lepra Society is addressing. We are addressing the social needs, psychological needs, and also the emotional needs and the economic needs of these persons.
Yeah, and I often describe leprosy, leprosy especially, but also LF, as probably the most prejudiced against disease in the history of humanity.
Yes.
Is that true?
Yes.
Why do you say so? Arun, tell us more.
There has been a lot of stigma in the community. Say that, though it is 100% curable, if at all it is been directly detected. But the challenge we try to see is, as Jimmy has rightly pointed out, because the identification itself is a big challenge. Because if at all a person contracts this disease, unfortunately with respect to low immunity, he doesn't really get the symptom doesn't really prompt them to approach to a facility. Like for example, it's a tuberculosis or any other things. They try to have some pain or some or other issue. But the leprosy is a disease of nerves and also with respect to the skin disease. So just they have the patches and they could not really get into the facility.
So tell me more about prejudice.
Yes.
Yeah, I know it starts at the family level, and I've met people whose relationships with their husbands and wives have broken down because one of them has been diagnosed as positive with leprosy or LF, because there is, and in the family, then in the neighborhood, in the school, in the village, in society at large. Is that discrimination and stigma still very prevalent, or do you think it's better than it used to be?
So there was a time that actually people were isolated. Even still is happening, but when it comes to the proportionate and with respect to our counseling and our efforts at the ground level, it is being really reducing.
So we do have a community dialogue and community campaigns about the disease and the treatment aspect, so that people can come forward by getting awareness, and they can have a treatment aspects, and we assure them that the treatment is available at free of cost. So in such a way, we are engaging different community members and also the key stakeholders. Even the political peoples or the key influentials were being identified, mapped, and we do talk with them, and we'll tell them that there should be a political commitment towards the disease and also towards the disease affected persons. So in such a way, we are working to reduce stigma and discrimination in the communities.
And also, more importantly, we are also having a patient support groups. Mm-hmm. What we try to do at the community level is we try to group the patients to have the stigma reduced. So we try to ask them to come together to discuss their issues, to advocate for their rights, particularly wherever it is possible. Unfortunately, Jimmy, actually there are about more than 100 laws against the leprosy patients.
Yeah.
So these are discriminated laws really sometimes really cause an issue. Like for example,
often they're arcane laws, aren't they? They're old laws which just haven't been repealed.
Repealed, absolutely.
And they're things which, for example, deny people affected by leprosy the right to travel on public transport, or vote in an election, or participate in some aspect of civil life. Is that right?
Absolutely. And one of the law is related to the wife and husband relationship. If at all a person gets a leprosy, it becomes a valid reason to apply for a divorce. So in some of the state, it is shocking to hear, but in some of the state, it is reality.
Yeah, and that's exactly how I feel. Again, when I travel to India and Bangladesh, I always want to meet groups of people affected by leprosy and LF, and I always ask the question, how is stigma and discrimination now? Is it any better? Is it worse? Is it the same? And people generally always say it's a lot better than it used to be.
Absolutely.
It's a lot better than it used to be, but we've still got a long way to go.
And coming down to the discriminatory laws, earlier it was more than 200.
Yeah.
Slowly, with respect to the ILEP agencies, International Leprosy Federation Organization
Yeah.
India, we are just trying to work closely with the government of India to repeal these laws at the court level, at the state level.
And this is what inclusion in our strategy
Absolutely.
means to me. It's about empowerment, it's about rights, it's about giving people affected the opportunity, the platform to advocate for their own equality in society.
I think it was
And all-
important that when we created the strategy, that we did such an extensive consultation.
Yes.
And the consultation included those who were suffering from the disease and their families, as well as those who were in healthcare or whatever.
Exactly.
So we have the voices translated into the strategy. And of course, you also have the voice of patients in Lepra Society. And we are working at Lepra UK to see how we can leverage off that as well.
Yeah.
Because it's important that voice is in the room. Whenever we're not making decisions for people, we're making them with people.
Yeah. And that's our strategic commitment, isn't it? Indeed, our mission statement in the new strategy says that we work in partnership with people affected by leprosy and LF. And that is a really important statement to the world about how we work as an organisation, how we view the inclusion of all people who we work with in determining our own work and agenda ahead.
So we also are building network and strengthening our networks with the different collaborators like academicians, like corporates from the cement factories, pharmaceutical companies, food processing units, so that they can also support us for the cause of leprosy.
Good. And sorry to interrupt, because I want to ask you a question about the cement factory that you mentioned, because you took me there a couple of years ago in Krishna. Yeah?
Yes.
Krishna block, Krishna district in Andhra Pradesh. And when we talk about inclusion, another aspect is quality of life and livelihood. So you're running a project with a local cement company which helps give startup loans to people affected by leprosy and LF to start businesses to enable them to have access to a livelihood which otherwise they don't have the opportunity for in society. Tell us a bit more about it.
Yes, the cement factory is Ramco Cement Factory and the KCP Limited, like where they are quite generous to support for the leprosy work. Initially, they used to support for the HIV programs, but it took almost 5 to 7 years for us to sensitize them, to show the persons affected with leprosy, taking them to field and also explaining about the issues that were being faced. So they came forward and they are now supporting almost 100 plus livelihood opportunities for the persons affected with leprosy. And presently we found that they are leading good, respectful and valued life and dignified life in the society. This is one of the things which we want to replicate in the other states also, where in the 2025 strategy, economic aspects were also being included to support the persons affected in terms of leprosy and LF also.
Brilliant.
Yeah,
Thank you, Radhika. Yes, Arun.
Just to add, Radhika, actually we are approaching to the corporates also. In the last few years, we could there. Basically, what
So
we see is
companies in
companies
India.
in Andhra Pradesh and as well as Telangana and in other states. So where we are trying to approach them to support the leprosy affected persons. If at all a leprosy affected person is a key breadwinner in a family and is contracted with the disease, and their economic condition is low, their children education is also gets affected. For that kind of initiative, what we could really approach to a company called Oracle, and in the past they could really support us to give the education support for about nearly 1200 children. So where in which we could really support the education of the leprosy patients' children from the 8th class to almost nearly degree standard. This was a program that has been run for about nearly 3 years, and we could really make the difference.
Right.
And more particularly, what we are trying to do is we are trying to focus on the girl children education, particularly now. We are trying to approach to many other donors, and also thanks to Lepra also we are just trying to have with respect to their funding. We are just trying to reach out to the girl children for their education, so that we are trying to have more girl children coming up and also taking their education irrespective of their family life and their condition. We are just trying to support them so that after the education also they try to contribute to their families.
Great. Thank you, Arun. Now let's move us on again Remember, there are 5 key points we wanted to tell everyone about. One is leprosy and lymphatic filariasis. One is health. One is inclusion. The next one is innovation. There's a reason why we've identified research and innovation, isn't there? In our theory of change,
Absolutely.
which we developed as part of the strategy, what we're saying is, over the last 100 years, the world has made great progress on the number of cases of leprosy coming down and new treatments being brought out. We're making progress against the transmission of lymphatic filariasis, but we've stagnated. Over the last 15, 20 years, the number is kind of flatlined.
Absolutely.
We're not making enough progress. We're not being able to push it into the next phase, and we're never really going to be able to eliminate leprosy or lymphatic filariasis without innovation, without new ways of caring, treating and supporting people affected by both lymphatic filariasis and leprosy. So that's why we want to do it. But how are we going to do it in practice?
Yeah, actually there are some of the, as a part of our research wing and as well as with respect to the innovations, what we are trying to do is we are working on with our team to have new diagnostic methods. Particularly we are just trying to, with respect to the nasal swab diagnostic, and with respect to the PCR testing, we are just trying to have with respect
Like
to
COVID PCR
COVID
testing.
PCR testing. So we are just trying to work on the diagnostic side. And the treatment side also, with the support of the Lepra UK, we are just trying to find out new regimens, particularly along with the WHO and other internal ILEP organization. We are working closely together to find a new regimen. If at all we just try to see the regimen of the leprosy patients, it's still 1 year of the treatment they need to really take. It's really a big job for our community health worker and also the patient to take 1 year of the treatment. We need to find a solution to reduce the, at least the duration of the treatment is concerned. And another aspect is with respect to the footwear is concerned, as Suzanne ma'am has already said, will not really give as a part of the luxury or other time. We just try to give the footwear as a part of the treatment to reduce the ulcers. So we are trying to see that there is a lot of need among the community because it's a lifelong condition for leprosy patients. The ulcers keep coming and they have a need for the footwear for the community altogether. So we could, with our facilities we are having in 146 locations, we are trying to reach to minimum population, but there is a need for the many. So for that reason, we are just trying to see that using of the technology and the AI, so we are just trying to see that we try to reach to more number of the people.
Good.
Like for example, we are just trying to have a digital measurement of the footwear, because for any patient, actually for any normal person also, it is also said that the 2 foots are different, and for the leprosy patient it is so basically some foot and foot conditions are different, and it
So
will be
everyone
very
has to have tailor-made footwear.
tailor-made foot, customized footwear
Yeah.
particularly. So through this application, mobile application, something, we just try to get the application and we just try to get the footwear measurements.
Great.
Also for strengthening the general health system in terms of building their capacities on leprosy and lymphatic filariasis, we are coming up with the digital learning systems, like where we could, with cost effectiveness, we can reach to more number of people, where we could able to have a digital learning systems apps with other ILEP organizations, and we are collaboratively coming up with new innovations for building the capacities of the
Super.
grassroots level workers.
And I know that there's a new app under testing now, which is basically a digital patient record, isn't it?
Absolutely.
Yes.
This person came, this is the name, their location, their family history, their age, their sex. This is what the services they refer to, the drugs they were given. I think that's a great innovation, and that's going to be rolled out in the next few
Yes.
months, isn't it?
Yes, it's a great innovation because we want to measure the outcomes and the impact of the work what we are doing in the field. So I think this would evidence-based, using the technology and innovations, evidences will be developed and it can be shown.
Brilliant.
And it can be replicated even by the other organizations, and we can also, if we look into the outcomes and the impact, we can design some other new programs which can be helpful for the community at large.
Great. Thank you, Radhika. So we've got one of our key points yet to come. Suzanne, I'm going to come back to you to ask you about that in a minute. We've covered health, inclusion and innovation. This is what we do. This is what we're out to achieve in the world. We've talked about lymphatic filariasis and leprosy. and on an equal footing in our vision. The last thing, we've spoken about it a bit earlier, one Lepra. We have this approach we call one Lepra. Radhika, Arun, Suzanne and I, we are part of one family. We are different limbs of the same body. We just happen to be either in India or in the UK, but we are all one part, one family. And this is a strong part of our culture. Our DNA as an organization always has been, always will be. We work together, but we all work differently in our respective ways. So in the years ahead, in this strategy period up until 2030, we're taking an approach, we call it the One Lepra approach. Suzanne, can you tell us a bit about what that means? What does it mean to you?
We see Lepra Society as being much more at the head of global leadership. And it's important that happens because basically, as we've just been talking throughout this podcast, the diseases are where you are. They're in India and they're in Bangladesh. And it's important that, in fact, your Lepra Society has the strength and the robustness to take on more and more of that global leadership and become actually the head of the body. But to do that, for Lepra Society to really become the global leader of the Lepra One family, it means a very robust governance. It means being able to, in fact, lead on fundraising, as I was just saying, to lead on program development, particularly data collection in a consistent way, and the advocacy for those who are suffering from leprosy, LF, and their families. Because these, while I know the national laws have been struck down by the Supreme Court in India, as you were saying, many of the states still have these archaic laws still on the books, whether they're enforced or not. The very fact that they are there is discriminatory. So for all those reasons, one of the big drivers of the joint strategy, for which we have a memorandum of understanding underneath it, is the fact that we want to see power shift to India, to Lepra Society, to be, in fact, running the show and us working with them.
Exactly. And Arun, what does that mean from your perspective in Lepra Society?
Yeah, actually, we always see Lepra as our big brother and guiding force, definitely, ma'am. But with all your support and guidance and the Lepra UK guidance, definitely I think we'll try to reach the guidance, reach the goal what we plan to have. And more importantly, as rightly said, the focus is at India, because India is nothing but India is carrying about nearly 50 to 60% of the global burden of the cases there. And we also need to really work on extending our resources to reach out to the needy. With all your support, definitely I think we can just try to make it.
Exactly. I often say that we could triple our size and only work in India and it would still be a drop in the ocean. And we see the next 5 and beyond, 10 years in India as a great opportunity for Lepra Society to become more autonomous, to be more self-sustaining, to raise more of its own funding within India for its own purposes, to achieve the ambitions that you have to reach more and to have impact for more people affected by leprosy and LF in the country. So yes, that's right. That's what One Lepra means to us. And for me and Suzanne here in the UK, we're working with our counterparts on the Lepra Society board in India and the executive team of which Arun is a member. And it's really encouraging to see how that is nurturing and moving forwards. And so it's a good journey for us to be on as we move forward into the future, rethinking about where we have our resources, how we generate our resources to ensure that they're as close as possible to the people we're working with and for in India and Bangladesh, and therefore having the maximum impact for people who we work with and for.
Sure.
We know that leprosy isn't going to disappear. Even if it's eradicated, as some people think it could be. It takes sometimes 20 years for it to actually demonstrate itself in the human body. So while Lepra does not want to be there 100 years from now, I hope there is no need for Lepra in 100 years from now. There is a need now, and there is a need now for Lepra Society to step up and to be a robust, well-governed institution with excellent employees such as we have next to us today, Jimmy, because you are needed, we are needed. Leprosy is not a disease of the past, it's the disease of the present, and at least for the medium-term future. And that's why what you're doing is so important.
On that word, thank you all very much. It's been a pleasure to share these microphones and sofas with you. Really great to hear your inputs and thoughts on the strategy. The 5 takeaway points are: we are Lepra, we are one Lepra, we work in leprosy and lymphatic filariasis, and we work for the health, inclusion and innovation for people affected by leprosy and lymphatic filariasis. And that's what we've always done, and that's what we're going to continue to do in our next 5-year period. Thank you all very much for joining us today.
Thank you, Jimmy.
Thank
been a
you,
pleasure.
Jimmy, for this wonderful opportunity. Thank you.